We know from an analysis that one of the insurance companies in Germany 2016 made, where they showed that only 6% of patients with ulcerative colitis were treated with biologics and only 9% of patients with Crohn's disease. So this is a dramatic underuse of these drugs. There are some centers out using 75% of patients with biologics like ours, and there are others, even more modern ones, using biologics in about 60% of the cases. And all these, the indications were guideline oriented. So this is the story of TNF alpha is not finished yet. I would expect that the numbers will increase in the future because the drugs get cheaper, so more patients have access to these drugs. So the field is still open for TNF alpha antibodies. At this point of knowledge and studies that we have and experience, for us and all the other experienced physicians, it's clear that TNF alphas will be in the center of any biologic drugs that we use in Crohn's disease as well as in ulcerative colitis. We have 20 years of experience. We have all these studies. We know that it's safe in pregnancy. We know the side effect rates. We know our drug. We know the players. The infection rate is low, and we can handle all these things that are related. There is some intolerance to the drug, and that's where we have the other drugs for. But the main player will be the TNF agents. And I think also when you look at as post-operative experience, there are two good studies, the POSER and the PREVENT trial, showing that these so far are the only drugs that really can prevent recurrence of inflammation in Crohn's disease. So this will always stay in the center. But honestly, I would say that this is only true for about 60–70% of the patients. For the rest of the patients, we need other drugs, and that's what the other mode of action players like IL-12, IL-23, and anti-integrins and JAK kinases are good for. That's what we have to. That's why we have to use them in the second line. And it's also we have to be honest. This is also a question of costs. When you have a drug that you can start with, that is an affordable drug even for society, for other societies like in the European Community, we have poorer countries. And we have to give them a chance that they can treat their patients. And I think, so we are happy to have the other mode of actions, and we will use them in the second line. Anti-TNFs are the central players in the treatment of IBD. But I think that at this time, we only use the most valuable and expensive drugs very late in the course of disease, where structural changes have already taken place. And I think, and this opinion is supported by many studies, that we have to use effective drugs much earlier in the course of the disease. The earlier you start with effective drugs with low rates of side effects, then the better the results are in the end. You can save patients from structural damages and functional losses. So I think this is the task of the future. For drugs who want to be a part of the market, they have to show that they have a preventive action also, as all the TNF-alpha antibodies do. They have a preventive action. The earlier you give it, the better the outcome is for the patient. And I think this is for the next 10 years. This is the task what vedolizumab, the JAK kinases, and ustekinumab have to show. They have to show their preventive action. And until we have these data, until we can compare them, we have to stick to the key player. And the key player has always been, so far in the last 20 years, is TNF agents.